Hi, this is Dr. Mahadevan with Dr. Stevens, and we're here to present How to Read a Chest Radiograph Part 4. On the last lecture, we finished with diaphragm, and now we're at E, or edges. So what are we doing with regards to edges? We're tracing the edges of the lung field to look for air or fluid, and the questions that we have are, is a pneumothorax present or is a pleural effusion present? And generally what we're going to do is start at the level of the hilum and sort of trace with our eyes around the edge of the lung to see if there's any air or fluid. And keep in mind, generally on an X-ray, we can see the costophrenic angles on the AP or PA X-ray, which represent a large costophrenic recess where fluid can accumulate. And one of the subtle findings that you'll see is blunting of that costophrenic angle because of the presence of fluid. So here is our first example.
So starting around the periphery of the lung, I'm drawing, looking round the lung margin, and what suddenly catches my eye is I can see an extra edge here. So I'm just going to trace it out and then we can get rid of that and just show you. Okay? And so we can see a lung edge here. And so beyond the lung margin, you can see that there are no lung markings. Okay? So this is a fairly sizable pneumothorax. I'll draw along the margins here. And you can see beyond the pneumothorax, you are no longer able to see any lung markings. So a fairly substantial one tracking along the chest wall once you do see a pneumothorax. Obviously, you want to look for associated rib fractures, but sometimes people can get spontaneous pneumothoraces, particularly if they're long, skinny individuals, and so they may not always have a precipitating history of trauma.
And Dr. Stevens, this one is a fairly large pneumothorax, but there are cases where it's a very thin sliver of air, correct? And so without looking carefully for it, you might miss it.
Correct. And then one of the important things, whenever you see a pneumothorax, even if it's supposedly small, you want to make sure that you're still seeing a third of the heart on the right of the spine and 2/3 of the heart on the left, because sometimes you can get shift of the mediastinum, which is an extremely important finding.
That, in fact,
so in this example, so this patient is again a trauma patient. You can see they're taken in a supine position on a trauma board. When we're looking around the margins of the field, as in this example, so I'm going to start here and just extend down here. Can you see, compared to the other side, that you've got a lot of lucency here? So this is air rising up and filling the anterior costophrenic recess, and this is called a deep sulcus sign. So you can see that there's gas extending right down into the costophrenic recess. And then you look at the mediastinum, that the mediastinum is shifted completely over to the left. You can actually see the lung herniating out and pushing the heart and mediastinum over, and you can imagine what's going to be happening to all the vessels coming into the heart. They're going to get compressed, and so this is characteristic of a tension pneumothorax and needs a chest drain pretty quickly. Another patient, so again you can see here we have a very large meniscus compatible with pleural fluid, and you can also see this hazy density here, and this is usually fluid that layers behind the lung and sometimes can track along in the fissures of the lung. So here we have some fluid tracking along in the oblique fissure of the lung. So a large pleural effusion filling about 50% of the right hemithorax.
Great, and then next we're going to look at the lung fields. And when we're looking at the lung fields, what are we looking for? We want to look at both lung fields. And again, as Dr. Stevens mentioned earlier, compare the two. We want to look at lung expansion and then evaluate the lung parenchyma. And the questions we have are specifically directed towards the presence or absence of any abnormalities. And those would include things such as infiltrates or opacities, air bronchograms, silhouetting of the heart that might indicate the presence of an infiltrate or fluid, and interstitial markings, increases in vascularity, and then finally masses within the lung field. So let's take a look at some examples of each of these.
So in this patient, when we're looking, you can see that the heart is of a normal size. The lungs are, of equal density. And again, you're seeing the nice pleural margins. Again, you can see nice pleural margins here. And so this looks like a normal chest X-ray of interest. You can actually see that this is a child's X-ray because they have unfused epiphyses here. But this is a normal cardiomediastinal silhouette, and both lungs are clear in this example.
So normal chest X-ray.
In this patient, you can see that the patient have a pacification in the left upper lung. You can also see a suggestion of air-filled bronchi here, so you can see some subtle air-filled bronchograms, which is characteristic of consolidation. And you've also lost visualization of the aortic arch, and so this is characteristic of left upper lobe pneumonia. Also, just can appreciate that the left hemidiaphragm is not clearly seen, and you can see a little bit of increased density, again, perhaps with a few air bronchograms here. So the patient also has a left lower lobe infiltrate as well. In this patient, we've got now a pacification of the right upper lung. Again, a suggestion perhaps of these branching linear structures here compatible with air bronchograms. You've also lost the silhouette of the right base, so they may well have some consolidation there, but you see this hazy appearance of the right base, which is usually indicative of layering pleural fluid. So they certainly have an effusion and right upper lobe pneumonia in this case. Now the patient, so it looks similar. Here we have some opacification at the right base, and you want to be able to see the right hemidiaphragm. And here you can actually trace the right hemidiaphragm relatively well. And so now we want to look at the right heart border, and you can see that we've now lost the silhouette of the right heart border. And so this is characteristic of right middle lobe consolidation. So it can look very similar, but if you've got a right lower lobe pneumonia, you would lose the right hemidiaphragm. If you have a right middle lobe pneumonia, you lose the border of the right heart.
So using the silhouette sign in this case can indicate where the infiltrate is located, because it's just looking at the pure location itself may not tell you whether it's
Correct.
mid-lobe or lower lobe. Wonderful.
So in this patient now we're going to look at the left heart border, and so when we're here we have the aortic arch and we're following it down, and suddenly your left heart border has disappeared, and you can see that there's a patchy infiltrate here, sort of irregular increased density just adjacent to the left hilum. And then when we come more distally again, we're seeing the left hemidiaphragm contour. So this is characteristic of Lingula consolidation, so consolidation within the lingular lobe. So again, the silhouette sign is very useful in these cases to determine exactly where the consolidation is. In this patient, again, we're looking, you can see in this patient, you can see the heart border nicely. We want to follow along the contour of the left hemidiaphragm, and you can clearly see here that we've completely lost that contour, and there's too much density here. So there's retrocardiac opacification concerning for left lower lobe pneumonia in this example. The patient also has some blunting of the left costophrenic angle, so almost certainly they've got a small pleural effusion as well in this case.
So if we were to trace out the right hemidiaphragm, we can see it very clearly all the way to the right border of the heart, but as we trace on the left, right about here, it stops and we can't really see it anymore because it's being silhouetted out by this retrocardiac infiltrate. Wonderful.
So in this case, it's a little bit difficult to see how big the heart is because you can see the patient has a prominent scoliosis of their spine, but their heart does look a little bit enlarged. What's interesting in this patient, you can see all these branching linear structures here, so reticular prominence. And if we look carefully at the lung bases here peripherally, you can see that they have multiple small lines that extend along to the pleural margin. And these appearances are characteristic of interstitial fluid, so in this patient with interstitial pulmonary edema. Quite commonly they also get associated pleural effusions, but this is indicative of a patient with interstitial pulmonary edema. We have another patient. This patient, we had 3 subsequent x-rays. In this patient, the heart does appear of a normal size, but again, you can appreciate all these fine reticular markings really throughout the lungs. And when you look carefully at the left base, you can see here again that the patient has septal lines or curly B lines. So these short linear structures that extend out to the pleural margin, and this is compatible with interstitial pulmonary edema. If we look at the patient's next chest x-ray, you can see now that you're no longer able to appreciate the sharp margins of the lung markings. So the lung markings have become indistinct. You can see that the patient's heart now appears somewhat enlarged, and they almost certainly have developed a pleural effusion because you have this hazy opacification at the lung bases. So this patient was in interstitial pulmonary edema, and now they're developing more advanced pulmonary edema. Patient continued to deteriorate, and now again you can see that the heart looks enlarged, and you're now getting these fluffy areas of increased density in the lung compatible with alveolar or airspace disease, and so this is florid pulmonary edema. So you can see it can progress from interstitial pulmonary edema to alveolar edema. And again, the lung bases in that case, you can see that there's blunting of the costophrenic angles, hazy opacification at the lung bases, and almost all of these patients are going to also have pleural effusion. This, again, you've got to look carefully around the lung field to make sure that there are no additional findings in the lung. So we're looking around the left lung, and the lung field looks clear, maybe a little atelectasis at the base. Looking around the right lung, suddenly you can appreciate that this patient has a small irregular mass here, and this is just adjacent to the right hilum and turned out to be lung carcinoma. So make sure that you look carefully for any pulmonary masses.
That has been How to Read a Chest Radiograph, Part 4, with Dr. Mahadevan and Dr. Kate Stevens. Thank you.